Hi, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today we are presenting highlights of a recent webinar discussing the treatment of immune checkpoint inhibitor-mediated myocarditis. The topic is presented by Dr. Nicolas Palaskas, who is Assistant Professor of Medicine at the Baylor College of Medicine and attending at the MD Anderson Hospital in Houston, Texas. This highlight will focus on treatment, monitoring, and future directions in therapy. Don't forget to check out the ICOS website at ic-os.org and also make plans to attend the GCOS Summit this September in Madrid, Spain. Without additional delay, here is Dr. Palaskas.
Now going on to the treatment. So glucocorticoids or steroids are really the mainstay of treatment. There have been some studies showing that there's lower major adverse cardiovascular events and lower peak in troponin with high dose versus low dose steroids. And this means really high dose. I mean, the studies are arguing for 500 to 1,000 milligrams of IV methylprednisolone for 3 to 5 days, followed by either an oral and IV steroid taper. Now, if you compare the taper of steroids for immune checkpoint inhibitor myocarditis that's been published in the literature compared to the taper that has been done for viral myocarditis, they're very different. So the taper for immune checkpoint inhibitor myocarditis has been really over 4 to 6 weeks is what most people are publishing, and that's what we do here. We do a taper of about 4 to 5 weeks compared to viral myocarditis, where these steroid tapers lasted at the very shortest 3 months, most of them going to 6 months to a year. But really, our cancer patients don't have that long to be on steroid tapers, and steroids come with their own complications. Now, how do we monitor patients going forward after they have myocarditis? We've been doing troponin monitoring every 1 to 2 weeks after the myocarditis event. However, it is a non-specific marker, and we have seen lingering troponin T levels, as I presented for that patient, that took 13 to 14 months for the troponin T to go down, but they were off steroids much sooner before that, and we're doing just fine and still recovering. So, and it doesn't mean that just because the troponin is still elevated that we should still be giving them high dose or pushing the steroids on these patients. So other immunomodulatory therapy, various case reports and case series have been published in the literature of IVIG, plasmapheresis, which are more antibody-mediated compared to mycophenolate, more T-cell mediated therapy, and ATG, which is more T-cell, and then infliximab, anti-TNF therapy. And then, of course, the more two recent ones, alemtuzumab and abatacept, which have some New England Journal case reports of their effectiveness, but nothing has been compared in a systematic fashion to see if we really have more benefit with this immunomodulatory therapy. A couple points on infliximab is that this TNF-alpha inhibitor makes sense mechanistically. If you look at myocarditis, TNF-alpha elevation is very common. And then if you look at the mouse model, the TNF-alpha, antibody TNF-alpha really decreased the myocardial necrosis and improved survival. However, the big concern with TNF-alpha inhibitors or infliximab is their warning with patients with heart failure and worse outcomes for patients with advanced heart failure. And so there's been a lot of hesitancy to use infliximab. And I would argue that not all patients present with heart failure, and actually a majority are presenting with normal LVEF. And so when we look at their right heart cath data and look at how many have an elevated pulmonary capillary wedge pressure, we see that less than half of patients with myocarditis actually have an elevated wedge, and less than half of them at our institution have LVEF less than 50%. And the LVEF and the pulmonary capillary wedge are not really correlated very well. So if a patient has a normal LVEF and a normal wedge, I feel a little more comfortable giving them infliximab if they need it for their immune checkpoint inhibitor myocarditis compared to a patient that maybe has a decreased LVEF and an elevated wedge pressure indicative of heart failure. So this hints that maybe we need to tailor therapy for each patient more individually and not just have blanket statements for whether we should or should not use these agents. And this is what I was hinting at earlier when looking at the different grading systems of myocarditis. So there's 4 patients in this group 1B and 1A on their biopsy findings that we never treated with steroids and we never treated with any other immunomodulation who did just fine from a cardiac standpoint and continued on their immune checkpoint inhibitor. And so that's where I think there may be value in this grading system, is identifying patients that we really should not be treating as full-blown myocarditis despite having an immune infiltrate on their endomyocardial biopsy. The next therapy that's garnered a lot of promise and is now going to be done in a multi-center randomized controlled trial is abatacept. And looking at that mouse model I presented earlier, the mice that were given abatacept had much improved survival compared to the mice that were not. Now, one interesting finding, if you look at part B here in the slide, is that despite them having better survival, the immune infiltrate was the same compared to the vehicle at 2 weeks. It was just at 14 weeks where you saw a vast improvement in the immune infiltrate, which I think is striking, that this therapy was so effective, but you still had a vast immune infiltrate in the myocardium of these mice. So here's a very aggressive protocol that we have instituted in some patients here at MD Anderson, where when they present with a neuromuscular immune-related adverse event, we initially stop the immune checkpoint inhibitor, we start the high-dose steroids, and then we also give upfront plasmapheresis. This is followed by rituximab and infliximab. As we do the workup for immune checkpoint inhibitor myocarditis. And what we recently presented at ACC is that we saw there were no major adverse cardiovascular events when we gave this upfront immunomodulatory treatment protocol. We also had no mortality during the index hospitalization for these patients. And their response in terms of peak troponin T going to less than 50% of the peak appeared to be, at least there was a trend to be better than those that were getting routine treatment with just steroids and then using some other immunomodulatory as backup therapy or refractory therapy. Now, none of these reach statistical significance because the patient numbers are low. This is only looking at 90 patients, and looking at their overall survival, you saw an early separation that tends to come back together, also not statistically significant. But giving the upfront immunomodulatory protocol, we found that the patients were making it out of the hospital more than giving this refractory therapy immunomodulation. So we're continuing to study this in patients going forward, whether this therapy will be beneficial, and hopefully with more patient numbers, we can see if an upfront immunomodulatory approach will be actually beneficial. Now, looking at the peak troponin values, this also hints that maybe we should be tailoring the therapy more. You can see that in the higher toxicity or a higher grade of toxicity, the median values are actually not very different at all, but you limit these peaks in troponin T when giving the upfront immunomodulation. Compared to the routine treatment versus upfront immunomodulation in lower grade toxicity, you actually have lower peaks in troponin T for those that don't get the upfront protocol. So, maybe we should be tailoring this protocol only to more severe patients, which, this was retrospective. So because of selection bias, that's probably already happening a little bit. Most people are not going to go for an aggressive immunomodulation if they're really low grade myocarditis. But that would argue in our favor, even for the adverse events that are happening, that we're self-selecting for sicker patients for this upfront immunomodulation protocol, and they're still doing better than those that don't get it.
I hope you enjoyed that excellent presentation. Don't forget to check out the ICOS website, where there is plenty of additional information regarding all issues related to cardio-oncology. If you're not a member, go ahead and sign up. In the meantime, this is Dr. Tom Murtaugh on behalf of the International Cardio-Oncology Society saying, treat cancer, protect hearts.